Okay, so today we just understand the basic principles of suturing. Clinically, what you have to do. The principles will remain same whether you're doing it for oral surgery or facial surgery or suturing in any other part of the body. So what we need are three things, three instruments: a needle holder, which holds the needle, a tissue holding forceps, which could be tooth or non-tooth, and a suture cutting scissor. Apart from that, of course, you need the suture needle, which is of different specifications, and we'll discuss that in another video, and a suture material. This particular suture is a 4-0 nylon suture, and the needle is a 3/8 reverse cutting suture. When we hold the needle holder, the first thing is that we use 4 fingers to hold the needle holder. The ring finger and the thumb are placed in the needle holder, and the first and the second fingers, they will be used for supporting while passing the suture through the tissues. Following that, the next important thing that we have to look at is what is the position of the needle within the needle holder. Many times the needle is held deep inside the needle holder. That is incorrect because it doesn't allow proper range of motion. We need to hold the needle close to the tip of the needle holder, and contrary to the belief where it should be held at the 2/3, 1/3 region, it is better to have more control when it is held midway from the needle tip till the base of the needle. If the needle holder is placed midway, it will give better control over passing the sutures and cause less bending of the needle while passing the sutures. Assuming that this is the movable tissue and this is the fixed tissue, you'll always pass the suture first from the movable, remove it from the fixed, and the bite depth and the bite width is two concepts that we have to understand. The bite depth should always be greater than the bite width, which means that the depth at which the needle goes in and picks up the tissue should be greater than the distance from the bite from the free end of the tissue. So the bite depth is how deep, how much tissue has been collected, and the bite width is the distance from the free end. When you do that, you will get something called as everted margins, and everted margins have favorable cosmetic and scar values. Okay, so while passing, you can either hold this tissue or just lift it up. It's essential to lift it up so that you can get a good bite depth. Always pass the needle from the center of the tissue. Don't try to take both bites together. Hold it with the needle, with the tissue holding forceps, and pull outwards. When you pull, don't pull straight up, rather pull straight forward. Keep a small end which you can use for tying the knots. Take the second bite at this exactly opposite at the same bite depth. After this, there is a knotting technique that I want to discuss because there's a lot of confusion with all practitioners regarding that. What we have in our hands is, this is the needle end, which is in my left hand. The needle is folded around my non-dominant hand, and it's secure inside, and the extra material is wrapped around my fingers. The needle is stored here. This is the needle end. This is the free end of the suture material. Place your needle holder parallel to the incision or the scar, and you turn the needle end twice around the needle holder. First step. Second step is cross over, hold the free end, lock your needle holder. Third step is cross both your hands. When you cross your hands, the knots are very secure and they will never open. Again, now come over the incision being between the needle end and the free end. Turn only one time. Hold the free end and cross over. With every knot, you will cross over the part of the incision. This creates secure knots. At the end, the knot is offset to either one of the sides so that it doesn't lie directly over the incision. And this can be cut. Depending on what suture material you're using, the number of knots will be determined. Usually the first knot will be of 2 throws and every subsequent one will be of 1 throw, following the same crossing variant. Just to show it again, this is the needle end, this is the free end. Common mistake that practitioners make is we go outside this V and try to cross the knots. We have to stay within these 2 free ends, within the needle end and the free end, right over the incision, parallel. Make it perpendicular, hold the free end, cross the knots. That was 2 throws in the first knot, following which we are going to do 1 throw in each knot and cross the ends. Offset the knot to one side, hold both the ends and cut adequate amount so that it's easy to remove the sutures at a later end without troubling the patients. This technique that we followed is called as the simple interrupted suturing technique. There are many other suturing techniques and I'll show you some of them. Once you should first master passing the needle out at the correct points, making the proper knots, do the simple interrupted well, and then move on to different techniques which are very easy to follow. So the next technique which we are discussing is the vertical mattress. In the vertical mattress, the first one is a deep bite similar to a simple interrupted suture. This part remains the same except for it is slightly deeper bites. But now the vertical mattress changes because there are repeated bites. If this is point A, this is point B, those are 2 entry points. Now there is a point C and a point D. All 4 points fall in the same line, but C and D are much closer to the tissue end, the free margin of the tissue, and this causes better approximation of the ends and less tension across the wound. The same knotting technique is used where your hands are crossing. And knot is cut. So vertical mattress basically has got 4 points of entry: point A, point B, point C on the same side as point B, and point D comes out on the same side as point A, and the knot is tied where the first knot is, first entry point is. The next suture technique is called as the horizontal mattress. Again, all the mattress sutures are used so that we can get better approximation and in high tension zones. So 4 points of entry, point A and B similar to the vertical mattress or a simple interrupted. But point C and D are not in the same line but are adjacent at the same depth as point A and B. So crossing of the hands. Four points of entry A, B, C, D gives nice tight secure sutures. One other technique which is used more commonly in dentistry to suture over a socket like this, I'll show it first over here and then I'll show it over here, is called as the figure of 8. 4 points of entry, A, B remains same, but after B, the point of entry is from D to C, not from C to D. In a horizontal mattress, we would go here, but in a figure of 8, we are going from point D to C. In this suture, there's going to be a cross or a number 8 figure which is over the wound or the extraction socket. Showing you a figure of 8 on an extraction socket. Basically, you'll use the mesiobuccal, mesiolingual, distobuccal, distolingual, and tie the knot on the mesiobuccal. Four bites A, B, D, C, not C, D. If I would go A, B, C, D, it would be a horizontal mattress. This is A, B, D, C. Crossing over. So these are the basic suturing techniques, simple interrupted, good bite depth, get equal bite width, knot your knots properly, vertical mattress, 4 entry points, all 4 in the same line, horizontal mattress, A, B, C, D, point of entry is important, and figure of 8 is A, B, D, C. That's how it looks. After seeing the individual suturing techniques, I'll show you another technique called as the continuous technique. Simple interrupted. Suture is the first one. Tie the knot as per regular. once you have mastered suturing and you're very sure, you can take both bites together of both flaps. Both the ends of the incision can be taken together, but when you're a beginner, it's better to take separate bites. And now we keep taking continuous bites of equal thickness till the end of the incision. It's a faster technique to close long spans, but the disadvantage is that if one of the suture ends knots are loose or one of the sutures breaks, the entire incision is likely to break down. And suppose we want to end our suturing over here. This is our last region. This loop of the last suture will be kept loose so that you can use it to tie the knots. Free end is cut. One modification of the continuous suturing which we use commonly in OMFS intraoral suturing is continuous locking suture. I'll show you that as well. It's more kind of a sturdy repair. First suture remains the same as per simple interrupted sutures. Free end is cut. And in continuous locking, I will re-enter with my needle holder before I remove the needle and pass it between this loop, showing you both the sutures adjacent to each other so you can understand what the difference is when you look at it from the top. Again, passing the needle holder below this loop, you can also pass it like this later below the loop. You kind of get an extra layer. This is the extra part of the suture which is tightening it. And then we tie the knot. So you have the normal continuous suturing here. You will get this kind of an appearance on top, and you have a continuous locking suture out here, which has got this extra secure part. If you want to do a suture removal for a continuous suture, you will cut below the knots on both ends, and at this point don't pull any of the ends, split them all, otherwise it will become very painful for the patient during removal. If you have done a horizontal mattress A, B, C, D, B and C, it's kind of a square, 1, 2, 3, 4, A, B, C, D. To do a suture removal for this, you either have to cut below this knot here, or you can cut this loop on this side. So typically it's easier to cut this loop and the knot will pass through easily.